Good morning, ladies and gentlemen. My topic for today is patient safety in the intensive care unit. The extreme complexity of modern medicine has led to an increased risk of harming the patient. About 5 to 10% patients suffer some adverse event during hospitalization. A large numbers of these are potentially preventable. However, majority of adverse events are never reported and therefore they cannot be addressed. Reducing adverse events in hospitals involves many stakeholders and it requires a systematic approach to deal with. The care of ICU patients involves multiple consultants, many medications, and often life and death decisions are taken quickly. This makes ICU more prone for medical errors. In 2006, an Israeli study of 205 ICUs found an average of 38.8 events that compromised patient safety for every 100 patient critical care days. Most of these adverse events are related to medications, indwelling lines, airway, and equipment failure. To Err is Human was a landmark report published by the US Institute of Medicine in November 1999. It estimated that up to 98,000 deaths were due to medical errors. This was more than the deaths due to breast cancer, AIDS, and motor vehicle accidents, which were talked about at length. However, no attention was paid to medical errors. Errors are costly in terms of money and they cause loss of trust in the healthcare system by the patients and also leads to lack of satisfaction amongst healthcare workers as well as patients. More often than not, errors are caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to prevent them. Healthcare is a decade or more behind many other high-risk industries in its attention to ensuring basic safety. Almost 22 years have passed since this landmark report came out. So it is high time we pay attention to patient safety and improve the workplace safety culture, which is a crucial element for deciding the patient's outcomes. This requires strong leadership which pays attention and provides resources for achieving this aim. WHO has taken notice of the damage caused by medical errors and hence every year since 2019, September 17th is celebrated as the World Patient Safety Day and every year has a new theme. This year the theme is Safe Maternal and Newborn Care. Act now for safe and respectful childbirth. According to JCI, there are 6 international patient safety goals. Identify the patient correctly, improve effective communication, improve the safety of high alert medications, ensure correct site, correct procedure and surgery, reduce the risk of health care associated infections, and reduce the risk of patient harm resulting from falls. Patient identification is a crucial aspect. We should use minimum 2 identifiers such as name and a unique patient identification number. This should be used while administering medications and blood products, while collecting laboratory reports or specimens, taking imaging tests, and while providing any type of treatment. Avoid using bed numbers or diagnosis as the sole identifiers. Wristbands may be useful, but they are not available in all hospitals. And if the patient is conscious, we must refer to them by name and talk to them often. Improving effective communication involves clear written and verbal instructions. If an instruction is given in a place where multiple doctors are looking after a patient, the sister should write the name of the doctor who gave a particular instruction. Closed loop communication should be followed. Whenever you're giving an order to a junior doctor or to a nurse, it is important for them to repeat what you said and what they have understood and also to report back after the action has been carried out. Dr. Peter Pronovost and group studied the impact of the daily goals sheet. They found that almost 85% of the errors were due to communication failures. However, use of a daily goal sheet improved interdisciplinary communication and reduced the length of stay in ICU. This was based on principles of crew resource management. They found that before implementation of the checklist, less than 10% of the residents and nurses understood the goals of care for the day. However, after implementation of this daily goal sheet, more than 95% of the nurses and residents understood the goals of care for the day. And surprisingly, it also reduced the ICU length of stay from a mean of 2.2 days to 1.1 day. We have to look at other industries to learn important lessons. So a group of pediatric cardiothoracic anesthesiologists and surgeons looked at the Formula One pit stop, and they designed their own handover for complex pediatric cardiac surgery patients. They divided it into 4 phases: phase 0, 1, 2, 3. Phase 1 was pre-handover, where before the patient was actually shifted to the ICU, a sheet was given to the nurses and to the intensivists as to what the patient's diagnosis and surgery is, what is the condition of the patient, and what equipment is required, what infusions the patient is on. In phase 1, equipment and technology handover was done. In phase 2, information handover regarding the patient was done. And in phase 3, there was discussion and planning. After this, they found that the information omissions per handover came down and the technical errors per handover also reduced. Coming to safety of high alert medications. The high alert medications or high risk medications are anti-infectives, potassium and other electrolytes, insulin, narcotics, chemotherapeutic agents, and heparin. Also, there are look-alike and sound-alike drugs which need to be handled very carefully, and for all the high alert medications, there has to be a policy of double check. At least 2 people have to check the medication before it is actually administered to the patient. It goes without saying that these drugs require safe storage, safe dispensing. There should be a standard dilution method for them. All these drugs should be double checked, and LASA drugs should be very, very carefully stored. This is a standard dilution form that we use in our hospital. This is displayed in all our ICUs, and we are trying to implement it even in the wards. The color of the column in this chart is the same as the color of the sticker which is put on the syringe. To ensure correct site and correct procedure, we must definitely have an informed consent if the patient is conscious or from the relatives, and the correct site can be marked after doing a USG, for example, while draining a pleural effusion, and chest X-ray or CT scan should be displayed while doing the procedure. No talk on patient safety is complete without mention of hand hygiene, which is the most simple and cost-effective intervention to reduce the risk of healthcare-associated infections. Eliminating catheter-related bloodstream infections in the intensive care unit is a challenge for every team. The Johns Hopkins QI team implemented this intervention. They educated the staff, they created a central line insertion cart where all the supplies required for a central line were available. They also assessed the need for continuing the central line every day. They implemented this checklist for adherence to CRBSI guidelines, and more importantly, and this was the most difficult step, they empowered the nurses to stop the procedure if all the guidelines were not followed. The CRBSI rates decreased from 11.3 per thousand lines to 0 within 9 months. Seeing the success of Johns Hopkins, the Michigan State invited Dr. Peter Pronovost and his team to reduce the incidence of CVC line infections in Michigan State. This came to be known as the famous Michigan Keystone ICU project, where in 103 ICUs, the reduction in the central line infections was 66% after implementation of these very, very basic interventions. I highly recommend this book by Dr. Peter Pronovost to anyone who is interested in patient safety. The book is titled Safe Patients, Smart Hospitals. To prevent falls, side rails should be raised up at all times. Caregivers should not leave the bedside without raising the rails up, and agitated and delirious patients require constant attendance. Do not mobilize the patient without attendance, and if you are moving a patient on a stretcher or a wheelchair, please use the straps. We must ensure that the bedside table and belongings are within the patient's reach, that walking aids are within the patient's reach, glasses are clean and hearing aids are working, the patient has well-fitting footwear and anti-slip socks, and the nurse call system is within the patient's reach. Every hospital has its own peculiar problems. So when you're working as an intensivist in the ICU, have a keen observation for your own peculiar problems. and then devise ways to avoid them. It requires a culture change, which is not easy. It takes a lot of effort and time, and it requires repeated training of the staff. So devise your own protocols and checklists to address your peculiar problems. Incentivize people who are doing well, maybe a financial reward or a promotion reward, and all these things require constant reinforcement. Checklists are becoming more common in the ICU, and there was one study conducted which said that in ICU every patient requires an approximate number of 178 procedures per day. So even if healthcare workers are 99% correct and they make 1% mistake, they are still making 2 errors per patient per day, which is a huge number, and some of these can be very serious. So checklists standardize the process and they ensure that all actions are addressed. It democratizes the knowledge, and it reduces miscommunication between doctors, nurses, and patients. It reduces medical errors and improves the quality, safety of the patient care, and that also reduces the cost. The success of WHO surgical safety checklist and the surgical patient safety system has led to increased use of checklists in medicine. We devised our own checklist for safety. We had observed that these are some of the problems that we are facing in our ICU. These are the common mistakes. So we devised our own checklist, and it is being used in our ICU now. Again, I would recommend one more book for everybody to read. It is a wonderful book by Dr. Atul Gawande. It's called The Checklist Manifesto, and it borrows a lot from other industries and how we can apply it to healthcare. Alarm safety is another important area that should not be neglected. The resulting noise and visual warnings that alarms give can desensitize the staff and cause them to miss or ignore these alarms. It is called alarm fatigue. And if the alarms are not properly configured, it compromises patient safety. Hence, it is important to educate the staff how to set the alarms for a particular patient. Coming to medication accuracy at transitions in care, everything is fine when the patient is in ICU, but when we are shifting the patient to the ward, even if one important medication is missed out, it can cause serious harm. So we must write the drug prescription clearly in capital letters with drug name, dose, route, frequency clearly written. In the drug chart, instead of putting a dot, write the number 1, 2, 3, 4 so that the nurses also know how many drugs the patient is on. Double check all the drugs. Clear written and verbal instruction should be given to nurses for any addition, deletion, or dose modification. Do not forget to do renal dose modification. Give a detailed handover while transferring patients to the ward, and do not forget the medication the patient was taking prior to hospital admission. Patient safety during transport is again an important thing. A lot of ICU patients move out for investigations. Adequate personnel must be present. Appropriate equipment with properly battery charged infusion pumps should be present. The monitoring during transport should be same as what was happening in ICU. There can be checklists. There are checklists for intra and inter-hospital transport which should be used, and transport if it is really required. Now bedside ultrasound has become very common, and a lot of CT scans can be avoided if we can just confirm the findings on bedside ultrasound. And if you have the portable brain CT, that will also reduce some of your transports to CT only for brain CT. So in spite of doing all this, suppose you have an adverse event in your ICU, how do you address it? First is do a systematic investigation of the event called a root cause analysis. It should be completed by an interdisciplinary team that has expertise in that area which is involved in the event. Major focus should be on potential system failures that led to the error as opposed to simply attributing blame on the individual. If we start blaming individuals, the individuals will refrain from reporting their errors. So do not blame the individual. Encourage reporting so that you can fix the system and other people don't make the same mistake. Team training is extremely important. Use of simulation to train people is again important. Again, pay for performance. And definitely we need to innovate new approaches for preventing errors. So have your own patient safety program. The 4 general domains of the program are ensure compliance with patient safety regulations, respond to adverse events by performing a root cause analysis and implementing the targeted corrective actions, apply evidence-based risk reduction strategies that are not required by regulations but are considered best practices, implement strategies to meet and exceed patient safety metrics that are publicly reported or tied to pay for performance programs. To conclude, I would say healthcare has one of the most hardworking and dedicated workforce. Still, medical errors happen. Most often, faulty systems rather than individuals are the cause. So, we need to build a culture of patient safety. It may be part of human nature to err, but it is also part of human nature to create solutions, find better alternatives, and meet the challenges ahead. Thank you.